Fractures of the forefoot. The forefoot complex consists of 5 metatarsals, sesamoid bones, and the bones of the 5 toes. Joints include metatarsophalangeal and interphalangeal joints. Forefoot plays a very important role both in gait and weight transmission. It is frequently injured in sport persons. Fracture of the foot is classified as shown in flowchart 14.2. Mechanism of injury. Mechanism of injury is usually due to direct trauma to fall of heavy objects on the toes or the foot. Phalangeal fractures. Proximal phalanx of great toe. Direct trauma or twisting injury, avulsion fractures. Phalanges of second to fifth toes, direct trauma. Plain X-ray showing fracture proximal phalanx of great toe. Clinical features. Patient complains of pain swelling over the dorsum of the foot, dorsum of the toe, and restricted toe joint movements. Radiograph. Plain X-ray with the AP and lateral views helps identify these fractures and plan the line of treatment. Metatarsal fractures. Fractures of 1 to 4th metatarsals, direct trauma. Fractures 2nd to 5th, direct trauma, twisting injury. Stress fractures 2nd to 4th toes, repeated minor trauma. Common in policemen, nurses, soldiers, etc. and is called the march fracture. V metatarsal inversion, injury on a plantar flexed ankle, showing a march fracture. Jones fracture. This is a fracture of the base of the shaft of V metatarsal bone and is fifth metatarsal bone and is confused with avulsion fracture of the tuberosity of fifth metatarsal bone. It is due to twisting injury of the foot. Clinical features. Patient complains of pain, swelling of the dorsum of the forefoot and restricted foot movements. Radiograph, plain X-ray of the forefoot, AP and oblique views helps to diagnose the metatarsal fracture. Sesamoid bone fractures. It is due to the impact of the foot on a hard surface while the toes are dorsiflexed. Stress fracture due to repeated trauma as in dancers, runners, etc. Treatment goals is in forefoot fractures. Orthopedic goals to restore the normal anatomy of the great toe, phalanx, metatarsal and sesamoid bones. Plain X-ray of the forefoot showing multiple metatarsal fractures, showing sesamoid bone fractures. In phalanges 2 through 5 toes, perfect alignment is not very crucial. Metatarsals 2 through 5 needs to be restored as anatomically as possible. Showing the healing time and rehabilitation time in forefoot fractures. Lesser phalanx fractures, healing time 4 to 6 weeks, rehabilitation 2 to 6 weeks. Second, third, fourth metatarsal fracture, 4 to 6 weeks healing time, 4 to 6 weeks rehabilitation time. Fifth metatarsal fracture, 6 to 8 weeks healing time, 4 to 6 weeks rehabilitation time. Great toe phalanx, 4 to 6 weeks healing time, 4 to 6 weeks rehabilitation time. First metatarsal fracture, 6 to 8 weeks healing time, 4 to 6 weeks rehabilitation time. Sesamoid fracture, 4 to 8 weeks healing time, 8 to 12 weeks rehabilitation time. Rehabilitation goals: to restore the normal range of ankle and foot movements, to restore the normal range of MTP and IP joints in movements is classified in the following flow chart. To improve the muscle strength of long flexors and extensors of the toes, everters and inverters of the foot. Table shows the required healing time and rehabilitation time in fractures of metatarsals and phalanges. Functional goals to restore the normal gait. Note residual effects due to sesamoid bone fractures, weakness of flexor hallucis brevis muscle, due to fracture of first metatarsal bone, weakness of extensor hallucis longus and flexor hallucis longus, due to fracture of the lesser four metatarsals, weakness of extensor digitorum longus. Showing body taping for undisplaced phalangeal fractures of toes. Methods of treatment: lesser phalanx fracture, undisplaced fracture, body taping, body splints. Displaced fracture, open reduction internal fixation with K-wire. Second, third and fourth metatarsal fractures, undisplaced fracture or minimally displaced fracture, close reduction and short leg walking cast. Open displaced fracture, open reduction and internal fixation or external fixators. Fifth metatarsal fracture, acute avulsion fracture, short leg walking cast, displacement less than 2 mm, strapping and walking boot. Jones fracture, non-weight bearing short leg cast. Stress fracture, short leg cast. For avulsion fracture more than 2 mm displacement, open reduction and internal fixation with lag screws. Great toe phalanx fractures, undisplaced fracture, non-weight bearing and short leg cast, displaced or intra-articular fractures, close reduction, percutaneous pinning, open reduction and internal fixation. This is indicated where close reduction fails. First metatarsal fracture, undisplaced fracture, non-weight bearing short leg cast, displaced or intra-articular fractures, open reduction and internal fixation with DCP plates and screws. Sesamoid bone fractures, acute fractures, soft padding, strapping the MTP joint in neutral or in slightly plantar flex position. The foot is then placed in a short leg cast. Sesamoidectomy. This is done if casting fails or if there is persisting pain. Physiotherapy management. During the first 2 weeks, for stable phalangeal fractures, active range of motion exercises to the MTP joints. For fractures of first metatarsal, sesamoid and first phalanx, no range of motion and no strengthening exercises. Non-weight bearing for fractures of sesamoid, first phalanx, first and fifth metatarsals. Weight bearing for the stable fractures of the other metatarsals and phalanges. By the end of 2 weeks, active range of motion exercises to the second, third, fourth, and fifth metatarsals, interphalangeal, and MTP joints. After 2 weeks, for stable phalangeal fractures, isotonic exercises to long flexors and extensor of the toes. For metatarsal fractures, isometric and isotonic exercises to the ankle, plantar and dorsiflexors, everters and inverters. Partial weight bearing for first phalanx, first and fifth metatarsals and sesamoid bones. By 6 to 8 weeks, active assistive and passive ROM exercises to all phalangeal, metatarsal and ankle dorsiflexors, plantar flexors, inverters, everters, long flexors and extensors of the toes. For stable fractures, full weight bearing, and for fractures of sesamoids, first and fifth metatarsal and first phalanx, partial to full weight bearing. After 8 to 12 weeks, progressive resistive exercises are started to the long flexors, extensors of the toes, dorsi and plantar flexors, inverters and everters. Full weight bearing is now allowed.